You may have seen I sent out, there's been a couple of different introductions for this presentation, partly because I keep changing my mind about what I thought would be most relevant or interesting to present. And you know, you said, so I live in Singapore. I've been there for about 3 years, and we're doing a lot of work related to the Singapore health system and how can we improve health behaviors and health outcomes in the local population there. And so I thought it's worth spending 15 or 20 minutes or so talking a little bit about the context of the Singapore health system and maybe why it is how it is, and then based on that, introducing some of the research that we're doing and some of the implications. And so I think that probably would, well, that's what I'll focus on in the next hour. And then if you guys have questions, I'm happy to stay on and talk further. And definitely, please stop me anytime if you have anything you want to talk about. So as I said, first I'll talk about the health system, and then I'll talk just about a few of the projects that we're currently working on, and not in a lot of detail, because I don't think we'll have a lot of time, but if you have interest, I'd be happy to talk further. So let me just give you the background on the Singapore health system. Now, I teach a comparative health systems class, and one of the main things that I try to get across in that course is that if you look around the world, health systems vary considerably across countries, and in fact, that variation is not by accident. I like to think that health systems are really reflective of the identity of the populations that they serve. And so in the context of the Singapore health system, I'll talk about it in a second, but I want to give you some backdrop about Singapore and the mindset of the government in Singapore. And then you'll see as you go through that the health system in Singapore reflects the government's mindset very closely. And in fact, I would argue so does the U.S. system, in all of its franticness is actually fairly consistent with the franticness of the U.S. population as a whole. But Singapore, basically, if you look at the history and the culture of Singapore, there's really a very strong push for individual and then family responsibility, right? Where government will step in if they have to, but they really would prefer not to. And in Singapore, basically, it's a very capitalist system, such that they really think that people who are successful should get better stuff, and in fact that carries through into the healthcare system, as you'll see. So it's very different than, say, a communist or socialist context. And so I'll show you in a second that basically if you're rich, your healthcare is better, and they're not apologetic about that. In fact, it's true with lots of things in Singapore, and in fact. Singapore is not so litigious, and so you don't have the malpractice type issues that you would have in the U.S., and in fact the government caps payouts quite a bit, and those capping of payouts have implications for the healthcare system as well. The government, and we face this at Duke-NUS, the government loves competition as long as they can very closely manage it. So, for example, there are 8 public, and I actually use the term loosely, and you'll see there's 8 public hospitals in Singapore that are all owned by government holding companies. So they're sort of privatized government agencies. And they compete against each other for patients and for revenue, even though they're all government entities, right? And in fact, we as Duke-NUS compete against NUS for talent and for grants, and we compete against the other medical schools, even though we're all sort of, if you fold them out, we all are essentially owned by the government. So the government likes to foster this competition, but it's very managed competition. And you'll see in the healthcare context, you'll see the same thing apply. Now, there are lots of ways that governments will, or different entities will regulate scarce resources, such as healthcare resources. And price plays very heavily in how healthcare is regulated in Singapore, and in fact, not just healthcare. In fact, I don't know how much you guys know about Singapore, but if you want to drive a car in Singapore, you have to get a license to own a car. It's called a certificate of entitlement, and it trades. It basically trades like a stock. And right now, the COE is trading at 85,000 Singapore dollars, about 65,000 US. So it's $65,000 to buy the rights to buy a car. So the crappiest car in Singapore is about $90,000, yeah, or more. So it's crazy. But you'll see, so they use prices in lots of different ways, and they tax things very heavily if they think they're overused. And in fact, they have road pricing systems and all sorts of ways to manipulate how much people drive. So price is definitely something that the government has recognized as a way to influence demand. And so let's talk a little bit specifically about the healthcare context. And the important point, as you'll see, is it ties back very closely to the model that I just described in terms of the mindset of the population. So Singapore is a mix of public and private healthcare entities. It's got market principles, but with lots of government oversight. Now, health expenditures in Singapore, as you all know, expenditures in the U.S. as a percentage of GDP are about 18 or 17 something percent now. In Singapore, it's about 4%, right? So much, much cheaper, right? Now, I'll show you the system, and then I'll ask the question at the end of the lecture, or at least remind me at the end of the section, how do they keep it at 4% when the OECD average is about double that, and the U.S. is much higher? And you'll almost undoubtedly be wrong when you guess what the answer is, but I'll tell you, and it's interesting, but it's consistent with the model. So I'll hold off on that in a second. Now, so again, the key players are certainly the individual, the government, and the community, and I should say within the individual, the family context as well. So let me just run through each of the different models. And so the basic model for Singapore's healthcare finance system is called the 3M model: MediSave, MediShield, and MediFund, right? And so the MediSave model is essentially a health savings account. It's a fairly large health savings account that can grow over time. And so the MediSave is only good, or historically it was only good for inpatient care, although lately they've added a few what they call high-value services. So you can now use it for chemotherapy and for a few other non-inpatient services. But historically it was just for paying for inpatient care. Now, So MediSave is meant to be the bulk of where the bulk of the financing for health services comes from. So there's no risk pooling in MediSave. It's not like an insurance pool per se. But if you have, if you run out of your MediSave, you can tap on your family members. So your parents, your siblings, or your children's MediSave account. So this family-based risk pooling creates lots of interesting dynamics, right? In fact, I've actually had students in class who will tell me that they encourage their parents to quit smoking because they don't want to have to use their MediSave money for their parents' health services. And in fact, one of the challenges that is being faced in Singapore now is that you have this aging, Singapore is a very quickly aging population, and the older adults didn't save enough to pay for their health services, and so they're tapping on their children. And so basically their kids are depleting their MediSave accounts very early, and so they're not going to have money for themselves. And in fact, fertility rates in Singapore are the lowest in the developed world, 1.2. So they're running out of kids to even suck money out of. It's a real problem. By the way, breastfeeding rates are also the lowest in the developed world. So they don't have kids, and if they do, they tend not to breastfeed them. Unrelated, but it's interesting to think about. And in fact, there's economic reasons for all this stuff as well. So it becomes quite interesting and problematic. And by the way, the government also reserves the right to force family members to donate to their family if they need additional money. So again, it's individual and family responsibility, but the government will make you be responsible if you choose not to, right? So there's actually a court set up where you can sort of sue your family member to get the money out of their MediSave account if they don't want to give it to you. Yeah. And in fact, if you look at MediSave funding, about half of, for older adults, about half of the payment for inpatient health services comes from a child's MediSave account. So you definitely have transfers going from the kids to the parents for paying for health services. Now, so as is very common with these health savings accounts, there's also essentially a high deductible real health insurance plan called MediShield. And in fact, MediShield, there's actually different tiers. So you can get MediShield Plus, that's a better, but there are these MediShield plans. And in fact, one of the interesting things about Singapore is they've sort of caught on to some of the behavioral economic principles around default strategies and opt-ins and opt-outs. And so The MediShield plan is something the government wants people to get, and so they've created it as an opt-out program, meaning you automatically pay for it out of your MediSave savings unless you actually go in and do the work to not pay for it. And you can pay for it out of your MediShield dollars, which means you're paying for it out of pre-tax dollars. So there's very, very high participation in MediShield, and the government wants that because that way the government doesn't have to step up and pay. There's another program which is actually quite interesting as well called ElderShield, which basically if you have 3 activities of daily living, so 3 limitations, the government will pay you a couple $100s a month basically to help you get by. And the government, this is also an opt-out program, and in fact it's not a particularly good deal, and people are starting to realize that and opting out at higher and higher rates. But the government, they like this program because it's a way to sort of give people money and keep them out of the inpatient settings. And they give them a couple $100s a month in cash. Now, they don't actually pay for services. They just give them the money, and they expect them to do, actually, they tend not to care what they do with it. But anybody want to take a guess what people tend to do with the money? Mm-hmm. So, for those of you who lived overseas, what people tend to do is get a maid. They hire a Filipino maid or Indonesian maid, and then the maid does a lot of the health care for the older adults. And in fact, in Singapore, that's very common and increasingly common because it's much, much cheaper to get a domestic foreign worker than it is to use the healthcare system. And in fact, some of the maids that come from the Philippines actually have medical training. Some have nursing experience, and so you have to pay the government. This is typical Singapore. So it costs about $450 a month to get a full-time, 24-hour, 7-day-a-week domestic helper, which you could give a day off a week if you wanted to, but you don't have to. And then you have to pay the government another $250 a month. So, and there's about 25% of all families in Singapore have a domestic helper, and many of them are either taking care of kids or taking care of older adults. And so increasingly, this is the way that Singapore is taking care of their aging problem. And as I said, fertility rates are 1.2, and so you do not have a lot of kids available to take care of parents. It's more expensive to use the formal healthcare system, and so domestic workers are picking up the slack, right? And so we're seeing more and more of that. And in fact, the government, by paying cash out of these programs instead of using, paying for reimbursement, actually is sort of tacitly saying that's a pretty efficient system. So the government actually is not so unhappy about it. Yeah. And in fact, I'll tell you a little bit of an aside, but it's worth thinking about. So with an aging population, you have lots of health expenditures really being taken up by the oldest old. And in fact, the last year or two of life is where a lot of our healthcare resources go. And I'll talk a little bit about some of the interesting parts of MediShield in a second, but some of the health plans that you get, if you get cancer, for example, or other priority conditions, it also doesn't pay for services, but you'll get a check. You'll get a $25,000 check or $50,000, depending on how much insurance you bought. And so the idea here is you could take this money and you could get chemotherapy, or you could get whatever high-end care is available, or you could blow the money on a cruise or whatever, and the government and the insurance, they don't care. And in fact, there's certainly some incentive for the healthcare system for you to take that money and bequeath it to a family member or use it on other things, because that keeps you out of the hospital and it frees up an inpatient bed, and the government is very short beds. And so, from an economic perspective, the argument is if you give somebody cash and they choose not to spend it on health services when they could, well, that's probably a better strategy for them, or what we would say is it's utility maximizing. And so these types of things that may actually be sort of welfare or health reducing, if you're not getting the benefits of these drugs, may actually be welfare increasing because people are able to take the money and do the types of things they want to do. And ElderShield is really a nice example of that, where the government is saying, I don't care what you do with the money, this is the way the plan works, right? And so, that sort of model is actually not that uncommon in Singapore. And I'll talk a little bit more about that in a second, and sort of how Singapore and the U.S. really deviate in terms of how they take care of people towards the end of life. Now, the assumption behind MediSave, and you read this over and over, is that because it's individuals' own money, it doesn't distort behavior. So it doesn't have what economists term moral hazard, where people have this incentive to overutilize health services, where you have in a risk pool and insurance pool, right? It turns out that that's not true. People don't see their MediSave money equivalent to cash. And I'll show you some data on that in a second from one of the studies that we're currently working on. So, as I said, let me just talk a little bit about MediShield and some of the interesting things about it. So, MediShield was established in 1990 because Singapore realized that just the pure health savings account wasn't going to cut it. And as I said, there's more options, and it actually runs just like a high deductible health plan, but they do a couple of things to keep prices down, right? And I'll talk about that in a second. And as I said, almost everybody enrolls in the system. Actually, so let me, I think I have it on the slides, but let me say just a couple interesting things about MediShield. There's an age cap. So here, it's actually on this slide. So basically, once you reach 80 years old, you're no longer eligible for MediSave, right? So what are the implications of that? I mean, what essentially is the government saying? I mean, basically, what they're saying is, by the time there's a certain age where, like, we don't want to be transferring money from younger people to older people.
You've hit your ninth inning, basically.
What was that?
You've hit your ninth inning.
Yeah, you're on your own at this point. So unlike Medicare, where basically it doesn't matter how old you are, we're going to give you the best that's available, the Singapore government is saying, at this point, you're on your own. And in fact, it was 70 years old up until not too long ago. Now they've increased it to 80. But, why do you think that they do this? It's not solely to just be mean to old people, right? I mean, there's a real upside to this.
It keeps it cheaper for everybody else.
Yeah, right. So it keeps it much cheaper, right? Now, not only that, this is another thing. So the MediSave pool tops out. So there's an annual and a lifetime max. So basically, if you get too expensive, you're done, right? So there's some real incentives in the system to try to keep your costs down here. Otherwise, you're on your own, and you can spend out of pocket. So this is actually it raises some very interesting economic questions. So as people get close to the cap, or they're getting close to aging out, what kind of behavior does that induce? You might suspect that people might try to take advantage of still having the insurance and maybe getting some procedures or some types of things that they otherwise might not do. But then as soon as they run out, maybe, whereas I might get the high-end chemotherapy when I'm 79, as soon as I turn 80, now I'm paying everything out of pocket. Things look very different. And so we have an IRB in place. We're working, there's a Singapore-Chinese cohort that we're actually, it's data from 1992, it's still going, and it's a very large data set, and a quarter of the sample has actually died. It's an older adult sample. And so we have IRB approval, and we're linking all of the government. Anybody who has an inpatient, this again is very Singapore, anybody who's seen in an inpatient setting in any hospital, public or private, has to submit all of the data to the government. So the government knows length of stay, they know how much it costs, they know what the diagnosis and the procedure codes were. And so we're linking all of that to our Chinese cohort. So we'll be able to see what happens as people go in and out of eligibility for MediShield or who essentially go spend too much money. And so we'll be able to actually test. And this is nice because generally speaking, insurance is endogenous. So people who think they're going to get sick will buy insurance, and they'll buy more, or they'll get an HMO if they're healthier. So here you have exogenous variation in insurance, and it changes over time depending on age. So it's a really nice experiment to see what the implications are of having or not having insurance. And so that's a research project that we're about to undertake. So any comments or questions on any of this? Definitely. Oh, go ahead.
Well, it looks like you're about to get to it, but is the concept that when you age out, then this ElderShield would take care of you?
No, so ElderShield is different. So MediShield basically covers you for inpatient services at any age. ElderShield, you have to be, I forget what the age limit is, you have to be at least 60 I believe. I don't have it up here, unfortunately. But ElderShield covers you for non-inpatient services if you're disabled, right? Now, of course, the disability is sort of up to the discretion of the government. So there's a lot of concern that people they think they have 3 IADLs or ADLs, and the government says, no, you think you only have 2. So there's some concern there. But ElderShield is supposed to provide resources for people to help them stay in the community, whereas MediShield is to help people in the inpatient setting. So they're set up for different things. Now, I should say there is private insurance in Singapore available, but the uptake is almost exclusively to the expats. But that's changing over time because people are starting to realize that the government-sponsored insurance programs are insufficient. So, in fact, work sites are increasingly offering some type of insurance, and you can go buy like Aviva and Great Eastern. There are private insurance companies creeping up, and they're covering the things, just like what the Medigap programs in the U.S. used to do. They cover the services that the government programs don't cover.
What happens if you're 82 and you have a heart attack and you don't have any money? I mean, do they turn?
Yeah, so I'll talk about that in a second. Yeah. Hold that thought. Go ahead.
How much should citizens pay for the MediShield or MediSave annually?
I don't know if I have the cost up there, but it's pretty inexpensive. Much, much less expensive in the U.S. It's like hundreds of dollars a year. Yeah. So it's ElderShield. You start paying in at age 40, and you can't get the benefits for 20 years. So ElderShield is actually not a very good deal, but MediShield is cheap. And they keep it cheap by sort of having these maximum out-of-pocket maxes, as well as, getting out of the risk pool the oldest and the sickest. Right? It's actually a good deal unless you're one of those.
So the cost of the treatment is cheaper? Like if someone has to be out of pocket, like the chemotherapy example, is it cheaper?
It is cheaper, and in fact,
Here.
So you spoiled everything, but I'll tell you why it's cheaper. So. As I said, Singapore is about 4% of GDP on health services. The U.S. is 17%, and most other countries are somewhere in between. So sort of there's an obvious question is how are they able to stay at 4%? Right? That sounds pretty amazing. And so you might say to yourself, well, it's this MediSave thing. People are using their own money. That's got to be sort of reeling in demand, and that must be really what it is. It's not. Go ahead.
For ElderShield, do you need to pay premium for this, or it's all just government sponsored?
You do. So it comes out of it's another one of these opt-out programs. So every month it comes out of starting at age 40, it will come out of your MediSave account unless you opt out. So anybody want to take a guess about how Singapore is able to stay at 4%? Well, so I'll spoil it. Basically, they're sort of a monopsony purchaser of healthcare professionals, and so they squeeze wages way down. So the average clinician and the average nurse makes about a quarter of what they would if they were in the U.S., for example. And that model has worked well for the last 20 years or so, but they're having a really hard time sustaining it. Right? And in fact, for example, I don't know how much you guys know this, everybody who trains through a university or a medical school in Singapore, even Duke-NUS, is bonded, which means you owe the government a certain number of years after you finish your residency. And I think for Duke-NUS, Mike, correct me if I'm wrong, is it 5 years? So for your first 5 years, you're going to be working in a government hospital and making a very low wage. And if you look at the makeup of the staff in all of the hospitals, very few Singaporeans. Almost all of the staff in the hospitals come from the Philippines or Sri Lanka or Indonesia and work at very low wages. In fact, they have dorms set up where these people live in these very cramped quarters, and they work very long hours at very low wages. And the clinicians as well, it's not like they're not doing okay, but they're not doing nearly as well as they would had they gone other places. Now, the problem they're having is that private sector hospitals are coming in. There's 1 million expats now in Singapore who are driving up demand for good medical care, and they're pulling clinicians out of the public hospitals at a very high rate. And the biggest concern the government is having right now is how can they keep these doctors in the government sector without having to significantly raise wages, and the reality is they can't, and so wages are creeping up for the clinicians, and so they've recognized that this model of squeezing wages to keep costs down is really not sustainable. Go ahead.
I was just going to ask if they had a problem attracting health professionals to become doctors and nurses, and then what happens after those 5 years? And you just said that some of them go to the private sector. Do others migrate leave the country, go to other countries?
So, if you're Singaporean, you don't have a lot of options. Like, for example, if you did a residency program in Singapore, you can't come to the U.S. and practice unless you redo your residency program. So it's very difficult for people to go train and practice in a different country than they train in, certainly in the higher income countries like the U.S. And so Singapore has been able to attract talent and keep talent within Singapore if they're Singaporean, but the problem is really keeping them in the public hospital system as opposed to going into the private sector within Singapore. And in fact, they've been able to attract talent in some fields from overseas. A lot of it is from people who are bright, medically trained individuals from other low-resource countries where working and living in Singapore is much better than working and living in your home country. So they've been successful at that, but the model is becoming increasingly difficult, right, for the reasons that we just described. Other comments or questions? So as I said, so the government's role is really to keep healthcare affordable, and there's a little bit more in promoting a healthy lifestyle. But getting back to your question, Adam, there is a program called MediFund, which is sort of equivalent to our Medicaid programs for low-income individuals. Now, of course, before you can tap the MediFund program, you'll have to use your all of your MediSave money. If you have MediShield, you have to meet the MediShield cap. They'll tap all of your family members' MediSave accounts if they can, and they'll take your private money as well. And after all of that, it's not unlike Medicaid here in the U.S., it's not an entitlement program. So you have to go through all of your health spending first, submit, and the government will decide later whether or not you get the benefits. And so you can imagine, and in Singapore, like depending on where you live and who you voted for, there's no guarantee that you're going to get the MediFund. And so one of the major challenges that we hear is that the non-transparency of MediFund makes it a very risky gamble to try to get benefits out of that program. Right? So people would like to see MediFund more transparent and more into entitlement program, but right now it's not. And it really, truly is the funder of last resort. So it's very different from a Medicaid program. So I think we talked about that. There is a community voluntary welfare role. And in fact, for end-of-life services, the community plays a significant role in hospice and providing care in the community. The government likes this because the community does a lot of fundraising. The government will do some matching funds. But end-of-life care is interesting, and it's an area that I've been increasingly thinking about. One that, if you're thinking about palliative care, palliative medicine, this pay-for-performance idea is fairly uncommon. So, if you're getting treatment where you're getting some type of procedure, it's fairly common that the government will bill you for services. But in palliative care or end-of-life care, this sort of transactions around dying tend to occur less frequently. And in fact, Dan Ariely talks about sort of social norms and market norms, and my sense is that there's something inherently distasteful about taking money from people towards the end of life. And so what happens with the voluntary welfare organizations is that they never charge, but they always show up at the funerals with an envelope. And the hope is that the family members will donate, and in fact a significant fraction do. And so a lot of their money comes from donations, either from family members or from wealthy Singaporeans, and then there is some matching funds from government. So let me just talk about delivery. There is a dual public-private delivery system in Singapore, and patients are free to go wherever they want. And so there are 13, and I put the word public in quotes because these are basically holding companies owned by the government, including our Singapore General Hospital, which is the partner for Duke-NUS. So it operates independently, and it's got a bottom line that it needs to adhere to, but really, at the end of the day, it's owned by the Ministry of Health, a holding company. And then there are increasingly private hospitals that are now competing for patients from the public hospitals. There's a very large private GP, unlike the U.S., or like the U.S. used to be 50 years ago, these private clinics are almost always 1 or 2 person docs. They sort of open up at the bottom of these apartments where a lot of Singaporeans live, and the Singaporeans who live in the building will show up there. Most of them are not automated to any extent, although supposedly there's an electronic health record coming. But right now, they just have charts in there, and in fact, the GPs disperse medicines right from the clinic, and in fact, that's a significant portion of their revenue. And the government is hesitant to change that because if they were to change that and have pharmacies, these guys would all go out of business. And so what they do now is they charge maybe $15 for you to go in and see a doctor, so very, very cheap. And then they make it up on selling you all sorts of drugs that you probably don't need. So Singaporeans do take quite a bit of medications, and they can see the doctor very cheaply, and it's sort of the deal that the government has made with the GPs. But in fact, you can imagine, so you have a very fractured outpatient setting, you have almost no insurance in the outpatient setting, and a lot of insurance in the inpatient setting, and so there's lots of incentives to try to get things done on the inpatient setting where doctor shopping. So there's lots of problems with this model. But the reason this model exists is because the government reimburses these two things differently. And so there's no incentive, for example, to have any kind of vertical integration like you would if you had a managed care organization. So at some point, if the government changes their funding cycle, I think the first thing you'll see is a lot more integration of these private clinics. Again, the MOH, although there's 2,000 of these privates, they're heavily regulated by the government. And people use these, 80% of Singaporeans use these clinics for services. I won't go into the details here, just needless to say that, for the private sector, it's the private GPs who do most of the services, but in the hospital sector, it's the public hospitals who provide most of the care. Now, let me talk, I mentioned earlier about in Singapore, basically it's fine for rich people to get better stuff. That's very well accepted, and that goes for the hospital as well. So Singapore has something called a ward class system. So when you go to the hospital, you choose your ward. And basically, I just had knee surgery in Singapore General Hospital. I was in an A ward, which was air conditioned, and I had really good food, and I had a full consultant who operated on me as opposed to a resident. So this is a picture of an A ward, and actually looked quite a bit like my room. Now, the subsidies increase as your ward class goes down. So that's a B1. This is a B2 plus ward. You can't see the lack of air conditioning, but I can tell you it's getting hotter and hotter. And here's a C-class ward. And so basically, if you're poor or you don't want to spend the extra money, you'll be in one of these C-class wards with a bunch of other sick people, and it'll be hot. Whereas if you have good insurance or you're wealthier, you'll be in the nice, cool A-class ward. Now, this shows you a little bit about the different subsidies, but I think it begs the obvious question about, are health outcomes different for people who are treated in the different ward classes? And I can tell you for sure that A-class wards always get what they call consultants, the full physicians, and as you work your way down, you're more likely to get a resident to do your work. But the government will tell you that health outcomes do not vary by ward class. And if you ever tried to study that question, you would very quickly find yourself on a one-way ticket somewhere. Go ahead.
Are consultants, is that an attending?
So that's the highest level. I don't know, I'm an economist. They're the ones with the most training.
As in, like, not resident?
Yeah, not residents, yeah. Yeah, they have housemen as sort of the lowest level, what they call the housemen. They're the ones just out of medical school. Yeah. So that's the system. And so again, this is very consistent with the Singapore mindset that people, who are wealthier get better stuff. And there's no complaining about that. I mean, in my comparative health systems class, as I said, one of the main things that I try to get across is that health systems reflect the values of the populations that they serve, and to try to take one system and port it to another country, it would never work. So could you imagine trying to implement a model like this in the U.S. or in either the U.K., for example, it would never work, right? You just couldn't do it. But in Singapore, this is, people see this as a very reasonable way to ration services and to keep costs down, and they are generally fine with that model. There's a couple other programs that I won't go into, but I will say that taking care of the sort of oldest old and the long-term care is a major issue, and one that Singapore has really, other than bringing in lots of foreign domestic workers, they haven't really thought about how to deal with it. The government is sort of still in the stage of building more hospitals. They still feel like there's going to be a lot of old people, we better build a bunch more hospitals. And I think that's a mistake. And frankly, what I've been saying to them is what they really need to be doing is integrating and following a model more like Kaiser or Group Health, and forcing more integration and strategies to keep people out of the hospital. But right now, they don't have any incentives, and there's no payment structure in place for doing that. I've been following the U.S. healthcare reform at a distance, but the accountable care organizations, I don't know if they'll work as intended, but that sort of model, I think, probably has the right incentives to try to keep people out of the hospital and to try to maybe keep people healthier. And in fact, there's nothing in the Singapore model to try to do any of those types of things. It's very siloed, right? So that's the problem. So let me just talk a little bit about financing, and then I want to talk about some of my research. So financing in Singapore, there's something called a central provident fund, which is basically a forced savings account, which actually forces people to save for retirement, for buying a home, and home ownership. These apartments is greatest in Singapore than in anywhere else in the world. So almost everybody owns a home. And in fact, it's interesting. The way it works in Singapore is you live with your family up until your early 30s, and you work and you save a bunch of money in your CPF account, and then you, with any luck, meet a guy, and the two of you will get married in your early 30s, and you will immediately buy an apartment and move into your new apartment straight from living with your parents. So it's a very strange model, and I think that's part of the reason why they don't have a lot of kids, because they're living with their parents until they're in their early 30s, which I don't think lends itself very well to baby making, but we'll leave that for another day. But so because of this forced savings, everybody gets a home, everybody saves for retirement, and everybody puts money into their MediSave savings. And so your MediSave grows tax-free over time, and there's actually an interest rate that you'll get every year depending on how the economy is doing. And you can see that the contributions come in from the employer, and sometimes the government will actually kick in some money as well. Now, the average Singaporean has about $10,000 in their MediSave account, which isn't a lot of money, but that's where they stay. Now, interestingly, we have on a couple of our surveys asked people how much money they have in their MediSave account, and I would have thought this would be one of the things that people would know right away, but in fact, most people have no idea. And I think the idea is that it's just not something that they think very much about. They don't think about it the same as money, and they don't think about it, I guess, until they really need to use it, which I was actually surprised by, but that's what we found. Now, just wrapping up, does the system work? Well, on many levels it does. And in fact, if you look at health indicators, the Singaporeans do well on almost every health indicator relative to any other country in the world: life expectancy, cost, infant mortality. Maybe not great on equity, but certainly no worse on equity than the U.S., for example. And so it's doing well, but there are lots of challenges, and some are not so different from other countries, such as aging. There's going to be a real need to deal with older people who don't need to be in a hospital, but who can't live on their own. As I said, there's a shortage of health professionals. They bring lots of them in from other countries, but that's going to be a problem as they need more. Coverage, as I said, is not going to be good. Is not good for the elderly, and in fact, that's somewhat by design. The push to privatize and to pull people out of the public sector is having a big problem on wages. And then, of course, westernization. Now, I talk about westernization in two ways. One is westernization in terms of people you're seeing chronic diseases increase, you're seeing diabetes go up fairly high. Obesity rates have actually doubled in a fairly short time period. Still low by Western standards. But in fact, the other piece of westernization that I think is probably as troubling is, you used to think about, Singapore is 70% Chinese, and you used to think about Singapore like China, where you have this very close-knit family when kids respect and take care of their elders. That model is quickly going away in favor of a Western-type model, and so you have Singaporeans, generally speaking, are very capitalistic. They're very materialistic. So the women work. They really like to buy nice things. They like to have fancy cars and good apartments. And taking care of their appearance is no longer a high priority for them. And in fact, even having kids is not much of a priority, which is why fertility rates are so low. And so parents, or the kids, are now increasingly looking for ways to manage their parents without having them come into the home. So they're paying for the foreign domestic workers, and even now starting to looking for nursing homes. So the model in Singapore is changing, and it's going to make it very difficult to operate the way things did in the last generation. And so that's going to be a real challenge for the government, and they're really just now accepting that reality. So let me sort of switch gears a little bit, talk about some of my research. But again, I think that, you know, if you look at the healthcare system and you look at the government system in Singapore and sort of the values, you can see that this system certainly works in that population. But it also creates some interesting challenges. Right? So we're sort of looking at trying to do research and understand better this system, and how can we help Singapore in the transition, and what would we recommend to try to make their system consistent with the sort of the new mindset of the people and the challenges that they're facing in terms of rising cost pressures and the shortage of health professionals. Right. So let me talk about end-of-life care, which is an area where I've been doing increasingly more work, partly because there's such a need for end-of-life issues. So the main issue that we're interested in is understanding why people do what they do with respect to end-of-life care, and what does that mean in terms of health-seeking behaviors. Now, this, you know, given what you've just learned, you can imagine that end-of-life care is very different in Singapore than it would be in the U.S. In the U.S., it's a very simple model. What does Medicare cover? I want the best of whatever Medicare covers. That's generally how it works. Now, in Singapore, say you get cancer, right? Well, you can look at the cost of the various treatments, and you can look at how much money you have in your MediSave account, and you can look at what's in your kid's MediSave account, and you can look at, you know, what are the survival probabilities, and you can say, oh, I don't know if that's worth the money. And so what you see in Singapore is you see huge variation in, say, cancer treatment patterns for people with the same stage of diagnosis, right? Now, one of the things that I've tried to convince the Singapore government, and I'll try to convince you, although I haven't had any success with them, is that less care and poorer health outcomes is not necessarily bad, right? If people could get more care, but it's, you know, it's high cost and the benefits are not that great, and they'd rather take that money and go on the cruise or give it to their family members, you know, from an economist perspective, that's perfectly okay. And in fact, if you look at you know, late-stage cancer treatment, just as one example, it's not great value for money. I mean, you could argue that it's cost-effective based on some of the benchmarks for cost-effectiveness, but those are societal thresholds, right? Given individuals may see that as not a very good investment. And so here, where individuals are really making choices based on their own MediSave money or their own money, many are saying, it's just not worth it. And so for some of these things, you see health outcomes that are far worse than you see in other countries. But my point is, well, that's not necessarily a bad thing, because in these other countries, essentially we're taxing society to pay for what I would argue is pretty low value health services, and those monies could be put in other places. Right? Any comments or questions on that? Go ahead.
I see it from an economic standpoint, but I'm curious, do people have the ability to make an informed decision? Like, do they know that what the treatments are available, what it entails? And
so, great question. And I suppose there's a mix, right? But I can tell you there are many people in Singapore who will be sitting in the chemotherapy ward getting chemotherapy, and they don't know that they have cancer because their family hasn't told them. And in fact, that's very common in Asia, that you keep bad news from as many people as you can. And in fact, if I send someone an email and the answer is going to be bad, typically they just won't respond to me. It drives me crazy, but that's sort of common. And so it's very common that, and this is some of the work that we're doing, and I'll show you in a second, but it's very common that the doctor will tell the family member the diagnosis, and the family member may or may not ever tell the patient, right? And the patient may or may not get treated, and you know, that's just how it is. But certainly some people know, and some families know, and you know, we're trying to sort of get at your question is, to what extent does it matter, and how does it influence the care that they might get? As well as to what extent does how much money you have in your MediSave account, or whether or not you have MediShield, influence the type of care you get for end-of-life stuff. So you can see here, so we're looking at a lot of those issues. And right now our work has focused mostly on cancer, though we're extending that to other areas, including heart failure and renal failure. And in fact, organ donation is interesting in Singapore. The average duration that somebody spends on the wait list for an organ is 9 years. You can imagine some health deterioration if you're, say, on dialysis for 9 years. And so the value of getting a transplant at that point is pretty low. But also physicians, where you have this sort of high mix of services where some people are getting a lot and some are getting a little, patients are probably driving some of that, family members are driving that, but we think physicians are driving some of that. And what we hear over and over is that the private sector physicians are just giving everybody the most expensive treatments, even though the value of these things isn't very good, but they make tons of money. And in fact, chemotherapy doctors in Singapore are some of the best paid, right? Some of them will usually make over $1 million in the private sector, giving these expensive chemotherapy drugs, which the benefits of these I think are debatable. So, as I said, we're looking at sort of the extent to which stated preferences predict treatment choices. We're looking at other factors. We're trying to see if we can create a decision tool that would help people make decisions at what types of treatment is most appropriate for them once we understand more about their values and what they'd like to do. I won't go into too much detail about these projects, but let me just tell you a little bit about a project that we've done so far and where we're headed with this particular project. So this is a project where we're basically trying to understand people's willingness to trade off various end-of-life factors. And we'll use a technique called conjoint analysis to do this. But basically, we did some focus groups among older Singaporeans, and we asked them questions about what they see as very important. And so we came up with a list of 8 things that we thought were that they told us were the most important factors in end-of-life care. Comfort at the end of life, avoiding prolonging of the dying process, sensitivity, avoiding burden on the family, keeping costs down, quality, and having autonomy over decisions, as well as some sense of completion. So our question was, okay, so those are important, but how are they ranked? And so we did what's called a stated preference conjoint survey aimed at getting some results about the sort of the relative value that people place on these things. And in fact, the data for this has just come in, so I'll show you some of the earlier results. We're still running some analyses, but we're going to have complete final data in the next couple weeks. So the attributes that we focused on in this particular survey looked at pain, and pain is a big deal in Singapore because they're so anti-drug that they tend not to do pain management very well, and so a lot of people will die or even be in significant pain. So even for me, for my knee surgery, they didn't give me a whole lot of pain medicine. Fortunately, I had smuggled some in from the U.S., but you can imagine how it would have been otherwise, right? So pain is a big deal. Being a burden on family members is we thought, a big deal. Survival certainly should matter. Quality of the healthcare experience and cost, and then of course, who pays the bill, right? Does it come out of cash or MediSave or family members? And then we were worried about place of death, because in Asia, dying at home is very important for the Chinese, but some of the other populations actually would prefer not to die at home. So we thought that was important. And the way we identified these trade-offs is what's called conjoint analysis. And basically in conjoint analysis, you give somebody 2 or more scenarios. So for example, in scenario A, you have, think about you're in a case of moderate pain, you're 10 hours a week burden on family members, your survival is 4 months, very good health experience, but your cost is $20,000 out of a family member's out of pocket, and you die in an institution, versus scenario B, which differs along all of these dimensions. And so what we do is we vary in a very systematic way the levels of these things, and over we say, if you were in this position and you could choose between scenario A and scenario B, which would you choose? And after about 9 of these or 10 of these scenarios, I can tell you what you would choose with very high predictive power. And given that, I can then figure out your trade-off, say, between dying at home and having an extra couple months of survival. Right? So that's what's called stated preference or conjoint analysis. So if you look at this, take 15 seconds and think down the column whether or not you would choose scenario A or scenario B.
Is this saying that with scenario A, where you're spending more money and all this, you're only going to survive 4 months?
Yep.
But with all of the poor care, you're going to survive 6 months?
Yep. So basically, before we give the survey, we do a lot of education about sort of getting people to understand the levels and the attributes and the way the survey works. But in this particular case, yeah, you end up having a longer survival, but you have poor healthcare experience, and so it's lower cost. Yeah, in this particular case, you can imagine you come in and you're diagnosed, and these are the trade-offs that you're faced with. Now, sometimes we'll bring in uncertainty into this, but this was a sample, I should say, in this first case, of people 50 and above, and we were just saying, just to get an understanding of their trade-offs. Right? So let me ask the question, who chose scenario A? Raise your hand. Some of you. Who chose scenario B? So most of you, right? So what was the single biggest factor for those of you who chose scenario B? Anybody?
Paying out of my own pocket.
Paying? You wanted to pay out of your own pocket? Anybody? Pain.
Survival.
Survival. So you can see, even for those of you who chose scenario B, there are differences in what you were looking at. And so as we vary these things over 8 or 10 questions, you would change. And in fact, what we found, and we run what's called latent class analysis, and we do find particular classes where some people are much more concerned about pain, for example, or others are much more concerned about keeping costs down. We even found a group where dying at home was really important. And so we run these analyses, and let me just give you a sense of the types of results that we find. So this is sort of how a way to look at this data. So what we found here was that pain wasn't something that drove people's decision making unless it was severe, in which case you had a very high willingness to pay to avoid severe pain, which certainly seems reasonable. Now, when you see things like this for amount of care where it's sort of going up and down, what that generally says is this is an attribute that doesn't play particularly high. So it's other decisions people are making. So we actually were surprised, but being a burden didn't seem to be a driving force. And we suspect this is because most of the sample has helpers, and they're probably just thinking, well, the helpers will just deal with it. We don't mind burdening them. Now, survival, it turns out that survival also wasn't a big factor until it got up to about 16 months, and then you see things starting to go up. But in fact, if you're healthy or you're over 50 years old, this also isn't particularly surprising, because you say, well, what's an extra couple months, maybe in 10 or 20 years, that's not a big deal to me. But I'll show you in a second, you get very different results when you ask this question to people who are faced with late-stage cancer. And in fact, that in and of itself is a really important finding, because what it's saying is when people are healthy and they're making insurance decisions and they're thinking that they don't have a very high willingness to pay for life-extending care, then they might not be buying the right levels of insurance, and then when they get into that position, they're underinsured. Right? So that's problematic, but it could also be problematic where you say, well, now a very big push in Singapore, I don't know about here, is advanced medical directives and advanced care planning, where you're getting people to make decisions about what will happen when they're sick while they're healthy. But if they think one thing, if they think they would do one thing and they would actually do another, that too is problematic. And so we're looking at that by re-administering the same survey to people who are actually faced with that decision to see the extent to which these things are time varying and whether or not, when people are healthy, they think they would do what they actually do. And in fact, for our cancer sample, which I'll show you in a second, we also we have IRB approval to get all of their health claims data. So we'll actually validate what they're telling us by seeing what they actually do. Now, unfortunately, we have to wait until they die off before we can really see what they do. So it'll take a little bit of time, but I think it will be insightful eventually to see how that plays out. And that, too, is important, because if this thing is predictive, then these clinical decision tools actually make sense. If it's not predictive, then you wouldn't really want to use them in that capacity. Quality, if it's not horrible, then they don't really care. And this is important because it says don't put too much energy on sort of making the care really good, because people don't value it that much. Now, cost, the length of this line says something about relative value. So cost is really important, but it turns out payment type is really important as well. And I'll show you this more formally in a second, as well as there's a preference in our population overall for people to die at home. And so this is another way of looking at the data, but basically for this, what it's showing us is, in terms of the importance of these attributes, cost was the most significant driver and about twice as important as the other ones. And in the other ones, there was a lot of variation, but they all, on net, came in about the same. Now, of course, for any given individual, this would look different, but this is how it averaged across the population. So let me just show you willingness to pay. So based on our data, what we found is that people were willing to go from 4 months to 16 months, only willing to pay about $4,500. Now, I suspect, and I'll show you in real life, they would probably pay a lot more, but that's what they're telling us. But many of you know, and I know Shelby, you know, that's far less than what the society believes people would be willing to pay and what governments tend to use as willingness to pay values. But in fact, I'm not convinced that these numbers are that far off. There's a premium for paying for place of death. People are definitely willing to pay quite a bit of money to avoid severe pain, and these numbers actually don't sound out of the realm of possibility. I think that's fairly reasonable. They're certainly willing to pay some money to, you know, based on the amount of care from family members or friends. And in fact, if you monetize this at an hourly wage, basically they're imputing caregiver costs of about 13 Singapore dollars an hour, which is actually pretty close to what you would have to pay to get somebody to do this type of work. So also fairly reasonable. Now this gets back to the value of a MediSave dollar. And as I said earlier, the general feeling is that it's your own money, so you'll treat it like your own money, and that way you'll be a better steward of health services. Well, it turns out it may be better than a fully pooled insurance model, but it's certainly not like cash. And so the way I'm presenting this data is, how much money would you be willing to pay to avoid having to spend $1 on end-of-life care out of your family member's pocket? Because this was the one that they least wanted to do. So basically what they were telling us is, to avoid spending a family member's dollar, I'd rather spend $1.23 of my own money, $1.59 out of my family member's MediSave account, or $1.89 out of my own MediSave account. So if you compare this $1.89 to this $1.23, basically what it says is there's a fairly significant difference between my cash and my MediSave dollar. So you still are going to get significant moral hazard here, because people are discounting these dollars fairly significantly relative to these dollars. But in any case, what it suggests is that if I run out of money in my own MediSave account, I'm going to be pretty hesitant to use my family members out of pocket, and certainly out of their own out of pocket. And so again, this gets back to the idea that people may optimally, you know, restrict the amount of health services that they get because they don't want to be tapping on these other sources of resources. I think that's if you believe in this model, then it's important to understand that. And I think, as I mentioned, we're going to be able to get this meta-claims data and link it to this cohort and study the effects of what happens with real data at end-of-life care. So as I mentioned, we're going to see whether or not these are predictive of real choices by getting the actual claims data. And if they are, we'll be able to you know, see basically whether or not we can use the decision tool based on the Conjoint within a clinical setting to help clinicians, you know, structure treatment that's better, more consistent with preferences of patients. Now, I mentioned earlier that we actually are in the clinic doing the same survey to cancer patients. And so this is preliminary data, so I don't want to make too much of our cancer data. This is just based on half of our sample. But one thing you can see here is that these guys are they've seen the pain. And so their willingness to pay to avoid pain is actually even greater than what the general population was. Not surprising. Caregiver burden still didn't play out. This length is longer, so their willingness to pay for life-extending care is greater than what the general population thought it was. Similar results here. This wasn't particularly important. Now again, we have sort of higher confidence intervals on this, so we'll see how this plays out. But basically, you know, whereas the general population is telling us that they're not willing to pay for life-extending care, our cancer sample, the numbers are much flatter, which suggests that their willingness to pay is much higher. This is a bit flatter too, but we also again see sort of the consistent relationship between, you know, where the money comes from making a difference. And when we have our bigger sample, we'll have a better sense of to what extent these differ significantly, but still, again, home and institution matter. So just a couple other stuff we're doing on end-of-life care. Back to your point, we have a survey, our cancer sample. We're also sampling their primary caregivers. And so we're testing the extent to which the caregiver's preferences and the patient's preferences coincide, and if they don't, whose preferences are actually driving the healthcare decisions. So that work is actually ongoing as well, and in fact, we just got funded, I just found out yesterday, to do a physician survey and to test the extent to which variation in treatment patterns is driven by variations in physician practice patterns, which I suspect it is, but that's going to be a really interesting study to look at. We have actually a couple other conjoint studies funded in this area. This one is looking more at earlier stage cancers and looking at the extent to which things change over time. Actually, let me go forward there. And then we're looking not just at cancer, so we have one going on in heart failure, we have one going on in renal failure. We're looking at one that says whether or not advanced care programs, whether or not people's preferences are changing over time, specifically around advanced care, ACPs, advanced care planning, to see the extent to which these things are actually helpful in giving people stable preferences. And then I'll sort of go a little bit faster. Just to talk very quickly about some of the other stuff we're doing. As some of you know, I do a lot of work around behavioral incentives. Not related to end-of-life care, but some of our other work is looking at different choices around health-seeking behaviors, and as well as how can we influence those choices. And so we actually have 4 or 5 trials either in the works or about to kick off where we're testing different incentive strategies around behavior change options, and we're testing can we get people to be healthier or take their medications as intended using behavioral economics and different incentive strategies. So quite a few of those are kicking off fairly soon. In fact, one of them we just finished where we gave kids pedometers, and we gave them $25 a month Toys R Us gift cards, which only cost us $20 if they met their monthly step goals. And in fact, we also in order for them to get the gift card, their parents had to also meet some step goals. And so we had this feedback effect on the parents and the kids. And we found, I don't know how easily you could see this, but we found fairly significant differences in terms of meeting physical activity guidelines and step goals. And so this is work under review, but you know, $20 a month if you can keep kids active is a pretty good deal. So that work was just finished, but we want to do some more there. Medication adherence is a big deal. In fact, I've been talking with Sanofi, and Indonesia has just come back to Sanofi and said, look, don't talk to us about efficacy anymore because nobody in our country takes the drugs as intended, and unless you can figure out a way to increase adherence, we're going to stop buying your drugs. And so Sanofi is very worried about, Indonesia is going through healthcare reform, and in 2014 they're going to have a national model, and basically they're telling Sanofi and all the other drug companies, you know, you either increase adherence rates or you heavily discount your drugs. And so Sanofi is very interested in working with us on using different behavioral economic strategies to increase adherence. And in fact, we're doing a pilot in Singapore through some money we got from the Global Asia Institute to test an adherence strategy around diabetes and another one around glaucoma, because it turns out these glaucoma drugs, they keep the pressure in your eyes at appropriate levels, but if you miss even a day and the pressure goes too high, that can have essentially lifelong consequences. And so for glaucoma, it's really important to take these things as intended, but in fact, non-adherence rates are about 70% in Singapore. So it's a really interesting area to study. And then we also do a lot of health technology assessment. What I found in Singapore is I was basically the second economist in the country when I got there, and the first one wasn't particularly good. And so there was a pretty high demand for my services around cost-benefit, cost-effectiveness, and health technology assessment. And so we've published quite a few of these, and we have several ongoing. In fact, the one on the bottom just got accepted in ophthalmology. We published one in pediatrics recently. We had one on genetic testing come out in neurology. So we've had quite a good success in this area, and there's lots of work to do this kind of work there. And so I'll stop just in the final second. This is a paper that just came out this week. I just want to tell you, it's very interesting, so I'll just tell you quickly in 1 minute. But basically, there's a drug for epilepsy called carbamazepine, which works pretty well and is very inexpensive. But it turns out that among Asians, a very small percentage of them go on and get what's called Stevens-Johnson syndrome, or TEN, toxic something.
Necrolysis.
Yeah, something. It can kill you. It's not good. You don't want it. Or it can look like burns all over your body. And in fact, if you get it on the eye, you can go blind. So it's been known for quite a while that this was more common among Asians, but until a researcher found a risk allele, actually it was a Duke guy, nobody knew why. So now they have a genetic test that can test people for this risk allele and guarantee that they won't get these adverse drug reactions. But it's not obvious that it's worth it, because even if you test positive for the allele, the probability of getting these bad reactions is very, very low. It's only around 4 to 6%. And the genetic test costs money, and if you test positive, the alternative drugs are much more expensive. So you're putting people on alternative drugs potentially for their lifetime because they have a small risk of getting an outcome that most cases is not bad, but in some cases is really bad. And so the Health Sciences Authority came to us and said, can you help us figure out what to do? And so we did my PhD student and I actually, and a woman from Health Sciences Authority, did a cost effectiveness analysis. And basically what we found was that on average it's cost effective, but it's actually cost effective for the Chinese and the Malays, but not for the Indians, because they have a lower positive predictive value as well as a lower allele frequency. But based on this paper, the government is changing the label for the drug and recommending that physicians go ahead and do the genetic test, or recommend the genetic test for their patients. So this was really important for us because it shows that we're adding value, we're doing work that benefits the government. So it was a really nice example. So I ran over a little bit and I apologize for that, but I wanted to give you a sense of what the healthcare system looks like and what we're up to. So if you guys have questions, I'm happy to hang out.